Next, we'll have the A.K. Talwalkar Symposium. The conveners for this session are Dr. Rujuta Mehta and Dr. Binoti Sheth. Could I request them to please take over the session?
A very good morning to WIROC and a very big thank you because this is the first ever pediatric trauma participation in the prestigious A.K. Talwalkar Symposium. So thank you very much to the WIROC team, and who better to chair this than the father figure of pediatric orthopedics, who needs no introduction to any crowd in India and internationally anywhere. To preside over this as the Mahaguru, Dr. Johari sir, would you please come up on stage? Dr. Johari sir has been the pioneer of pediatric orthopedics in India. We all take inspiration from him, and we are very, very fortunate that he has literally raised the bar for pediatric orthopedics at every level, be it the president of IFPOS, be it the president of CCOT, IOA, and whichever organization you name it. Sir has really set a bar for us to see the pinnacles of achievement. I have a great team which my co-convener, Dr. Binoti Sheth, will introduce. But first, as is customary, we pay our respects to the pioneer of trauma in the city of Mumbai, that is Dr. Arvind Keshav Talwalkar. Late Dr. Talwalkar was the BOS president in 1969 to 1972 when most of us are actually born. And we would never know what that age had been, where he truly laid the seeds of the Bombay Orthopaedic Society Foundation. He was FRCS and MCH under Professor Mac Murray, the first Indian to walk into AO and do the AO devices, the first Indian to do the Smith-Peterson nailing, and then on the Austin-Moore process in India. And we, as we all sit here, owe the formation of the Western India region to him, and therefore we are in WIROC today. He was one of the founders of the Bombay Orthopaedic Society and laid the foundation of several Bombay Orthopaedic Society courses, which are our flagship events. He had an eye and insistence for excellence in everything, and also had an industry acumen. This is a photograph from the Royal Children's Hospital, Liverpool, where most of us don't know that he actually had a significant exposure to pediatric trauma, and some of the concepts that they believed about supracondylar are still very, very valid. I will leave this slide to your eyes with the last few words, saying that this is one of his favorite quotes, what Dr. Sumet Talwalkar has personally communicated with me, that you may not be the best or the brightest. Certainly you will never be the best looking. That ship sailed long time ago. But one of the things you can do is to work hard. And if we only learn to do that much, I'm sure we will be able to gain from the legacy of late Dr. Talwalkar. Without further ado, I'll invite Binoti to introduce our faculty.
So good morning, everyone. So for this wonderful symposium, we have eminent pediatric orthopedic faculty from all over India, and I request all of them to come on stage one after the other as I introduce them. So the first one, we have Dr. Sandeep Vaidya, who is from Mumbai, Thane, and he's attached to prestigious Sandeep Vaidya Hospital for Children, and he's also attached to Pinnacle Hospital, Thane, and Jupiter Hospital. Next, we have Dr. Sandeep Patwardhan from Pune. He has attachment with the prestigious Sancheti Institute, and he's also professor at Bharati Vidyapith Medical College, Pune. Next, we have Dr. Premal Naik. He's from Ahmedabad, city of Gujarat, and he's the director of Rainbow Super Speciality Hospital and Children Orthopedic Hospital, and he's also attached as an honorary pediatric orthopedic surgeon at NHL Municipal Medical College, Ahmedabad. Next, we have Dr. Manoj Padman. He is from Delhi, and he is attached to Rainbow Children Hospital, Fortis Memorial Hospital, and he has a center for pediatric orthopedics and disabilities. And finally, we have Dr. Taral Nagda. I think all of you know him very well. He's attached to many hospitals in Mumbai, SRCC Children's Hospital, Jupiter Hospital, and he's been pioneer in being a director for a CP clinic and gait analysis lab. We have our own good convener, Dr. Rujuta Mehta, who has been a pioneer in planning this whole program. She needs no introduction, but let me just tell you that she is the head of the department of this very good pediatric orthopedic hospital from where all of us have learned, that is Bombay Vaidya Children's Hospital. She's also attached to Nanavati Hospital, Jaslok Hospital, Surya Hospital, and she's the chair of Women Orthopedic Surgeons of India, that is VOICE, and she's a chair of Women of APOA Educate and Support, that is WAVES Group. And she's been actively involved in Bombay Orthopaedic Society as a secretary and also as a vice president. And to help her, finally myself, I'm attached to Sion Hospital as a professor and head. So without wasting time, I'm sure all of you are excited to learn about supracondylar. So let's invite our first faculty, Dr. Sandeep Vaidya.
We'll just briefly introduce the format before it. We've tried to keep it case-based and quasi-didactic. First, all the speakers will speak for 6 minutes each to different aspects of the supracondylar, which is what we encounter in life. And then there'll be a case-based discussion, which is almost like a reality show. There's going to be quiz. And the third aspect of it is going to be all of you, our audience, our most important people here, for you to be able to ask questions to us. So please participate wholeheartedly. Over to you.
Thank you, madam. Good morning, everybody. So in this first talk, we are going to revise and brush up our basics. And this is a brief outline of the topics which I am going to touch upon. So to start off, in any supracondylar humerus fracture, it is good to first classify the fracture according to the direction of displacement, because this tells us about the mechanism of injury and the reduction maneuver which is to be employed. So majority of the fractures are extension type, which can be displaced either in a posteromedial or posterolateral direction. A very rare minority will be flexion type. Gartland classification we are all well versed with. Type 1 undisplaced, type 2 is green stick with sagittal plane angulation, and type 3 is completely displaced. However, there are a few new additions to the original Gartland classification. So Wilkins subclassified type 2 into type 2A, that is pure sagittal angulation, and 2B, that is angulation plus rotation. An additional type 4 was added, which is a fracture with multidirectional instability. This indicates a circumferential periosteal tear. Therefore, these fractures are extremely unstable, difficult to reduce, and difficult to pin. Bach in 2008 classified supracondylar fractures according to the fracture pattern. So majority of the fractures are typical, that is transverse in the sagittal as well as coronal plane. However, there can be a few atypical subtypes. So in the coronal, the atypical subtypes can be medial oblique, lateral oblique, and high transverse. In the sagittal plane, the atypical subtype can be sagittal oblique. The significance of identifying the atypical fracture patterns is that the reduction is difficult, these are unstable, and you may need to modify your pin configuration in order to achieve good stability. Clinical evaluation of supracondylar fractures must include a neurovascular evaluation. A quick neurological assessment for integrity of all three nerves can be done by asking the child to perform the gestures of rock, paper, scissors, and OK sign. The 3 A's of compartment syndrome, namely anxiety, agitation, and need for increasing analgesia, should be looked for. A contusion or pucker indicates that there is a possibility that the spike of the proximal fragment may have buttonhole through a rent in the overlying brachialis muscle. This is important to identify because this makes the fracture difficult to reduce. Then coming to radiological evaluation. So type 1 fractures, many times the fracture line is not visible on day 1 of injury, and in such cases you have to rely on elevation of anterior and posterior fat pads. Additionally, in type 1 fractures, you have to be careful to look for medial column comminution. In this rare situation, the fracture can drift into varus due to collapse of the medial column later on. Therefore, these fractures should be stabilized with K-wires. Type 2A fractures, you have to assess the magnitude of sagittal angulation, and that is done by looking at the orientation of the anterior humeral line with respect to the capitulum. If the anterior humeral line is intersecting the capitulum, these fractures can be treated with cast in situ. However, if it is completely missing the capitulum, these fractures must be close reduced and pinned. Type 2B fractures are identified by identifying rotation, which is indicated by differential width of the proximal and distal fragments. All type 2B fractures must be close reduced and fixed. Finally, coming to type 3 fractures, and the gold standard of treatment here is close reduction, K-wire and cast. There are various options for OT setups and positioning of the child for this procedure. The steps of reduction: initial first step is traction against a counter traction applied by the assistant. The second step is correction of coronal displacement. And the third step is correction of sagittal displacement. This is done by applying thumb pressure to the olecranon and fully flexing the elbow. The reduction is then locked. This is done by pronation in case of fractures with posteromedial displacement and supination in fractures with posterolateral displacement. Intraoperative assessment of reduction is done by obtaining Jones view, pillar oblique views, and lateral view. Stabilization of a typical transverse fracture can be achieved by insertion of lateral K-wires. So the number of wires can be 2 or 3 depending upon the stability of the fracture. Out of these wires, the inner wire must pass through the olecranon fossa because this gives a stable forecortex hold. The outer wire is the pillar wire. Additionally, there must be sufficient divergence and spread between the inner and outer wires at the level of the fracture site. In the sagittal plane, the wire should pass from slight anterior to posterior. However, you may need to modify your pin configuration in case of atypical fractures. So for medial oblique fractures, you would need to insert medial pin. For high transverse fractures, you would need to insert intramedullary wires. And for sagittal oblique fractures, your wire orientation would have to be from posterior to anterior. So to conclude, you have to do a careful clinical and radiological evaluation to differentiate typical from atypical fractures. Type 1 fractures are almost always conservative except the rare situation of medial column comminution. Type 2 fractures should be close reduced and fixed if these fractures have excessive sagittal angulation and rotation. And type 3 fractures, close reduction, K-wire cast is the gold standard. Thank you.
Thank you, Sandeep, for a really succinct expose. I now invite the other Sandeep, so Dr. Sandeep Patwardhan, to take us from basics to difficult situations.
Thank you. It's an honor to be here in this symposium. And my job here is to take you through the slightly difficult ones, where there is combination or it's complicated. It's really not difficult if you know what to do, and I thank my friends for their contributions. What is the problem? You must understand the pattern, the combination. How do you tackle the swelling? How do you tackle anything that is blocking reduction, and your technique? So the first is the high supracondylars. If you see literature, they have classified the high ones, which are metadiaphyseal, into transverse and oblique. And what they say is that the obliques take more time for reduction and fixation, and there is more chance of loss of fixation and higher chance of varus as well as stiffness. So what you must realize is that if your fracture is slightly higher at metadiaphyseal, as Sandeep pointed out, one of your pins will tend to go intramedullary. And if it's oblique and comminuted something like this, you are likely to end up with a stable fixation on one cortex, but the second cortex is not engaged, it's intramedullary, and you might drift into varus malunion. There is a technique which has been published from a Chinese paper where they pass a trans-olecranon wire which goes intramedullary, so that you can achieve your reduction on that intramedullary wire, and then you do cross fixation so that you get enhanced stability for these kind of metadiaphyseal fractures. The low supracondylars are very interesting because despite good reduction, they end up with avascular necrosis because there's an end artery there, and you need to be careful and warn parents about that. The adolescent supracondylars again are different because there is high severity of injury and higher comminution, more surgical time, and higher chances of open reduction may be needed. And wires required, if you are doing wiring, is much more. You need multiple wires, which may cause more stiffness and callus formation in the fossa. A 12-year-old, multiple wire fixation, healed well, but you can see that excessive callus in the fossa causing stiffness. Multidirectional unstable, the type 4 again, where the periosteum is broken, you will need a joystick. So you pass a wire in the distal fragment, manipulate it, get it to your reduced position, and then pass your wires so that you're using that as a lever to control the distal fragment, and you can achieve your reduction. So there is a small way where you can do this. The flexion types can also be difficult, And again here, what you can do is a transolecranon pin. So you reduce it in slight extension, put a transolecranon wire, something like this, and go intramedullary, like the Chinese paper. And around this intramedullary wire, you can achieve your reduction in extension, and then you can cross pin it or use lateral pins as required, so that it does not hamper your reduction or fixation. And after you are done, you can remove that wire which is going transolecranon. Some irreducible fractures may need something like a leverage technique, an intrafocal manipulation, something to get the distal fragment out using a small K-wire on a T-handle and joysticking it using a leverage, getting it reduced, and then passing your pins. This is another example where there is excessive swelling and the fragment is widely displaced anteriorly. What you can do is use a small suction cannula. Make a small nick anteriorly, suck out the hematoma, push with the suction cannula the proximal fragment so that you can reduce the distal fragment against that and get your reduction. So this is another small tip for the difficult ones. The artery forceps technique Taral will describe for delayed fractures, but sometimes you have malrotation. There's an anterior spike and you're somewhat not able to reduce it. So what you can do is put a small K-wire in the proximal fragment and rotate the proximal fragment so that you align it to the distal one. Normally you have control only on the distal fragment, but a small K-wire can help you control the proximal fragment, and then you can go ahead with your fixation. Sometimes you have associated injuries like these where this is a comminuted supracondylar with a radius fracture with a Salter 2 lower radius. So what we could do here was anti-grade elastic nailing, which is divergent, holding the pillars, and then a radius ulna elastic nailing to control the forearm fracture. And this is how it was treated. Supplementary cast was given, and that is how it healed over a period of time with excellent function. Pucker sign does indicate irreducibility, and you should be ready to do an open reduction in case you cannot do these small tips and tricks that I showed you. An acute medial spike angle and a small tip skin distance should make you aware that you are going to likely to need an open reduction, and a low threshold is needed. Extensive bruising again is a marker that you are going to need an open reduction. This is my way of doing a reduction for the puckering. This is the arm board technique where I put a small micropore tape at the edge of a board. I've described and published this often. And then a gentle milking maneuver so that we can get the fragment reduced from the brachialis region, and then you can do your reduction and pinning. Open reduction, if you do not get adequate closed reduction or if there is a neurovascular compromise, please forget the midline triceps approach, which causes a lot of stiffness, adhesions of tricep, and you cannot judge the rotation and coronal alignment. The open reduction rational approach is to remove interposed structure and facilitate a closed reduction from front. So what you need to do is that if there's a posteromedial fracture or a posterolateral fracture, go anteromedially if it is posterolateral, find out where the median nerve and brachial arteries, reduce it, and then pin it. If it's posteromedial fracture, your incision will be anterolateral, the radial nerve will probably be there, reduce it, and then fix it. Thank you very much for your kind attention.
That was lovely, Sandeep. All difficulties summarized in 6 minutes. And orthopedic surgeons tend to get very nervous when it comes to a matter of nerves. So we have Premal Naik all the way from Ahmedabad telling us how to hold our nerve while we reduce difficult supracondylars.
Thank you, Rujuta. I'm going to answer a few questions which are burning in our mind. So we want to know what is the most commonly involved nerve. Will that nerve palsy recover? When should I intervene? And what should I do if I am the one who has caused the problem? So let's look at the answers. There are varied incidents of nerve, the most common being radial reported by say Series and Ogden, Brown reported ulnar preponderance, and Kramer reported that it's only the median nerve which got injured. Nerve transactions have been reported, but it happens only in the radial nerve, and that exactly very rare. So if there's a radial nerve palsy, you should be a little more worried than the other nerve palsies. But I think most important is which one do you look for first, because you have a crying child. Sandeep showed you how to look for it, but it may not be possible. So if it's a posterolateral displacement, you should look for median nerve or anterior interosseous nerve. If it's a posteromedial, look for the radial nerve, and if it's a flexion variety of supracondylar, try and look for the ulnar nerve first. Now let's see what the literature says about recovery. 18 injury in this JBJS paper, 9 injuries resolved at 2.5 months, remaining 9 were explored, of which 8 nerves recovered after neurolysis and 1 radial nerve which was completely lacerated, nerve grafting done, not recovered. But the conclusion, observation and supportive therapy initially is most important. If you do not get recovery by 6 months, EMG, exploration and neurolysis is warranted. This paper, seminal paper by Peter Waters Group, a single institute, 244 injuries over 16 years. Median nerve was most common, iatrogenics were excluded. Median time to recovery was 2.5 months approximately. 60% recovered by 3 months and 90% had complete recovery at follow-up. But there were aberrations, and I would like you to draw your attention to aberrations, that when there was a multiple nerve injury, it took 54% longer time, and when there was a single radial nerve injury, it took 30% longer time. So they concluded, in majority of the nerve injuries, recover within 6 months, you don't need any decompression. But if it is an isolated radial nerve, or if there are multiple nerve injuries, there will be a prolonged recovery, you can wait little longer for that. Another paper, British paper, a referral center, 17 years of experience, more than one nerve involved. They had a higher rate of exploration, about 56%. 13 were iatrogenic injury, of which 18 were related to K-wire, where there was a nerve penetration, epineural stripping, and 12 were trapped in the fracture site. But this was a referral center, so there is a high chance of exploration in this. So let's look at when do you explore. This 7-year female had a long spike as shown by Sandeep Patwardhan. She was reduced and fixed like this. This spike was not reduced. She had median nerve palsy. As you can see here, there was a puckering and she had a pink pulseless hand. So I did an open reduction, and doing open reduction, we explored median nerve, had nice reduction in radial nerve and median nerve recovered within 6 weeks' time. So now let's come to the most interesting type, ulnar nerve injury caused by the doctor. 6 cases reported in JPO. 1 was a hypermobile nerve which was fixed anterior, but 5 had a medial nerve placed in tubital tunnel. Nerve was penetrated in 2, restricted retinaculum in 3. Nerve was decompressed in all these cases. 3 full recovery, 2 partial, and they recommended exploring the nerve earlier. Compared to this Turkey paper, 473 children, 25 iatrogenic injury, they did not remove K-wire whether the nerve was involved or not, did an EMG at 6 to 12 weeks, sensory function recovered at 2 months, motor 5.4 months, and all the patients recovered without removing K-wire. Another paper with a meta-analysis, 375 children, neurological complications in 37, this paper from Nigeria. There was an anterior long sharp spike which Sandeep spoke about, 13 iatrogenic, all recovered. Conclusion is prognosis of nerve injury is excellent, especially the iatrogenic one, surgical exploration is not necessary. Coming to the most recent indication, large systemic review, 26 articles, 179 injuries, 85% managed expectantly, 17 had 179, only 17 did not recover, 26 cases explored. The conclusion is the majority of iatrogenic ulnar nerve are managed conservatively, 90% achieving full recovery, and literature does not support early wire removal. Now let's look at this child. 9-year female, fixed like this. Surgeon did not realize that child had ulnar nerve palsy. She came to me for fixed flexion deformity. Child was observed and she recovered without doing anything. This gentleman who wanted to prevent ulnar nerve by doing the organ pins entered, had multiple attempts and ended up injuring ulnar nerve itself. Another 4-year child, pink pulseless hand. He had he had good circulation and normal radial nerve preoperatively. I did a close reduction, I got good reduction, but postoperatively child developed a radial nerve palsy. The radial nerve was explored, and within 10 days child had a recovery of this. I don't know whether should I have explored or not. So coming to the final recommendations, when you have a nerve injury, what you need is close reduction, and you can observe this for 3 months. If there is no recovery, say by 5 to 6 months, look for EMG, consider for exploration and neurolysis. But the most important thing is don't get a nerve injury, do not use medial pin. And if you get an ulnar nerve palsy, the record says that you should remove the wire. You may not explore the nerve if it is later, but if you are in the early period, explore the nerve. Thank you for being with me, getting more confused, because confusion is the thing in nerve injury. Thank you.
Thank you, Premal. Taral just reminded me that we have Naik for nerves and Padman for pulse. So let's invite Dr. Manoj Padman from Delhi to tell us what to do when a child comes with the problems of pulse and supracondylar.
Good morning, everyone. While waiting for the slide to come up, it's a privilege to be invited to take part in the Talwalkar Symposium. I thank the organizers of WIROC and the session coordinators, Rujuta and Binoti, for giving me this opportunity. So my remit today is to present a rational approach towards managing this difficult problem when a supracondylar fracture presents without a pulse. So when we discuss this in any forum, the two common questions which come up in the minds are the timing of intervention. Do all of these need to be operated upon in the middle of the night? And what is the level of vascular support that you need in the management of these injuries? And I'll take you through what is the current evidence in terms of how these are managed, as well as my experience over the years. So the first thing that you need to remember is you need to identify the dysvascular limb, the ischemic limb, the white hand. That there is no debate, no discussion. That needs immediate treatment of the fracture followed by the vascular injury. You are left with the remaining, what we call the pulseless pink hand, which is equivalent to the pulseless perfused hand. And you need additional info before making a decision, not just relying on just pulse. And let me take you through a few real life case scenarios to illustrate my point. So here is a child who I got to see in the evening, although the injury happened almost 12 hours prior, but had been referred on by 2 centers because of lack of vascular expertise. But when I saw the child, it was perfused hand, the pulse wasn't palpable, with no neurological deficit. But the injury was almost 12 hours prior. Identical radiological picture, but presenting directly to our ER within 2 hours after the injury. Again, a pink perfused hand with no neurological deficit. And a third scenario, again, an extension type supracondylar fracture, the only difference here being that the child had an associated dense median nerve deficit. Now, all of these are identical broadly if you look at it. Extension supracondylar fractures, grade 3, pink pulseless. But they are 3 different clinical contexts. So in the context of managing these injuries, I would urge you to think beyond just pulse. P doesn't stand for pulselessness alone. And what do I mean by that? So the personality of the fracture, that's been well discussed by Sandeep Vaidya, so I'm not going to repeat that. That is a clinical and radiological assessment of the severity. In the context of vascular injury, you need to look at pucker sign. Apart from irreducibility, it means that the fracture has buttonhole through the brachialis and is abutting the vascular structures. Median nerve deficit and posterolateral displacement are well known to be associated with greater incidence of supracondylar fractures. You need to understand the limitations of radiological classification. This is a Gartland 3. This is also a Gartland 3, but the degree of soft tissue injury is much more. So what I tell my residents and fellows is that discuss these as Gartland 33 fractures, because the amount of injury is much more severe and it brings your mind to focus that you're dealing with a different beast altogether here. Then you look at perfusion. We all know how to look for perfusion, and in this context, my message is that perfusion does not mean just mere presence or absence of pulse. It's a lot more than that. There are adjuncts to clinical evaluation of perfusion. Pulse oximetry, looking at good waveforms, not just the number SpO2. Doppler triphasic signals are also adjuncts to clinical evaluation. They do not they cannot be relied upon in isolation to make any decision. Then you have patient factors, which does not come up in Western literature. We see late presentations, both in urban and rural settings, as well as other factors which determine where you are practicing, which may influence how you manage this. So if you look at all these parameters and you look at the first case scenario, it does not make any sense to delay this any further because it's already 12 hours post-injury. So this was taken up immediately, fixed, stabilized, no vascular input, child went on to recover well. Whereas the second case scenario, when you have a well-perfused hand with no neuro deficit, And if you are sure that you would have access to OT the following morning, you can safely wait in a much controlled environment and get the same degree of outcome. So this was pinned the following morning. And the last case scenario where there is a dense median nerve deficit, I would urge you to take these up urgently because it's just a matter of time before it becomes critical ischemia. So that's with regard to timing. What about vascular exploration in these pink pulseless hands? It's a mixed bag. If you look hard enough, there is literature supporting both views, the wait and watch and the proactive exploration. Over time, over these years, I think the wait and watch group is probably, there is more evidence to support it. They have enough reasons justifying that, the excellent collateral circulation. And the proactive exploration group would urge you to kind of intervene immediately and not lose the golden time. The AOS guideline sums it up. There is no evidence to support it either way. It depends on the context in that you're working in. And there are clinical algorithms which kind of help you to kind of identify this. This came up in 2015. And this is more recent. And if I can take you through this clinical algorithm. So you have a pulseless hand, if it's well perfused and poorly perfused. That's the first distinction. No doubt, poorly perfused, immediate fracture stabilization. Well perfused, you still need to be fixed early enough. But if you have adverse factors, namely a median nerve deficit, late presentation, I would urge you to take these up urgently. Once fixed, the story does not end with that. You need to monitor the perfusion, not just pulse, whether it's clinical or non-invasive modalities. Well perfused, observe for 24-48 hours. Poorly perfused or compromised perfusion, you need to again kind of get your vascular colleagues involved and you need to kind of investigate this. A few safety guidelines. Borderline cases, I would urge you to kind of keep them inpatient for a little longer. Post-fixation loss of any perfusion is critical, needs to be taken care of. So in the context of supracondylar fractures, rather than just discuss these as pulseless, look at it as perfused, well-perfused hands, poorly perfused hands. And that would kind of clear a lot of confusion. Thank you.
Thank you, Manoj. And now we invite Dr. Taral Nagda, who has probably faced many late situations. But this time on WIROC, he's been absolutely on time. So that is what we request him to be with his talk as well, be on time.
Absolutely. So I'm going to talk about late presenting supracondylar fracture. Firstly, what is late? According to literature, what will come with Sandeep's method, which is close reduction and fixation easily, which is within first 3 days, is in time, and anything which presents more than 3 days is late. A fracture like this, which presented 14 days, I want to know from audience what would be your plan of management. Those of you who feel that this should be open reduced and still fixed, just raise your hands. Okay, and those of you who feel that let it heal and we'll do an osteotomy later on, raise your hands. So house Rujuta is equally divided onto this. What happened to this patient was it was treated with open reduction and fixation. Post-op X-ray looks good, but elbow was stiff. Went to a bone setter and ended up with this because of manipulation. So there is always a confusion for late presenting supracondylar fracture. The debate is, as Premal has written in his paper, should we open reduce now or accept malunion and do an osteotomy at future? Then when you look at the papers, they are again divided. There are papers which say that you can open reduce and the tricks are posterior approach, which Sandeep asked us to forget, but you should remember posterior approach in these cases. You have to do VY-plasty of the triceps and you may require shortening. So it's a big surgery. And there are papers which say the results are not good. You can get myositis up to 25% and stiffness up to 30% in these patients with a nerve injury of 5%. Can these patients be managed some other time? So this is a paper from India published in CORR which showed a way that a delayed supracondylar fracture you can reposition. And he repositioned this with long traction for 2 weeks, admitted these patients, realigned them so that the incidence of cubitus varus was reduced. How do I manage? It's really not possible for us to admit these patients for 2 weeks to realign. So I have an out-of-box thinking and I'll show you how I manage late presenting supracondylar fracture. This was 7 days late. And as we have shown, supracondylar fractures have a different personality. We have associated injuries. So this is Montegia with supracondylar, which presents 7 days late. What will you do? Close reduction pinning, is it possible, or will you open this fracture or leave it alone? What we did is we took this patient under anesthesia. Under anesthesia, there was some mobility possible when we manipulated it, and because this was a fracture across the elbow, what we did is we did this artery forceps intrafocal reduction. So take a curved artery forceps, rotate it at 180 degrees and reduce the translation, and then use your proximal pin along with joystick. So all the tricks used here to get an acceptable reduction. Monteggia also dealt with by reduction and pinning. This was alignment and range of movement on table. At 4 weeks, we removed the K wires for supracondylar, and at 12 weeks, other wires came out, and this patient did well. Now, this is a 6-year-old child which is presented at 11 days. And by this time, you don't have this degree of mobility where you can even do an intrafocal pinning. This is how this child presented. If you leave it alone, this will head for cubitus varus and will require an osteotomy later on. Can we do something here? So this child who came with radial nerve palsy, what we did was we remanipulated the patient on table. Did not get a very good reduction, but we did get realignment. We prevented varus. And if you treat this now in plaster, it will spring back again into varus because of the callus formation. So what we do is, put it in the best K-wire position you can on table. And this child, though it looks translated over a period of time, healed well, no deformity here, good range of movement over a period of time, and did well. When patient comes to you very late, this is 8-year-old child, comes after 2 weeks, and you see that there is always already a callus formation happening here. There is no mobility. Child does not have any pain. This is a child I am willing to just not do anything, maybe put a slab for a week and then mobilize. So this healed well, the translation got corrected. There is some residual varus which parents are willing to accept. So no further treatment for this child. So the take-home message is rule of 10. If the child comes less than 10 days, but more importantly, if it's mobile, if you see under anesthesia, there is some amount of mobility which is there, I will do some indirect reduction, intrafocal reduction, proximal K-wire derotation technique, or joystick, but get a close reduction and put K-wires. If the child comes between 10 days and 20 days, you cannot get exact reduction, but manipulate into an acceptable position so that the child will heal without cubitus varus. Those who come very late have no mobility. I would rather leave them alone, and if required, do an osteotomy at a later date. So with this I end. Rujuta, 1 minute before my time.
So thank you all boys. This has been brilliant. Everybody's been on time or before time. Life is always like a reality show. And in pediatric orthopedics, especially with trauma, all the more reason when you're dealing with a supracondylar fracture, because it does not come as systematically as our faculty presented. And therefore, to bring out how they would handle it, the girls have put together a quiz. We have all Bahubalis, super skilled, who will be able to shoot all 3 at one go. But right now, they are blind. None of them knows which case is going to whom. So audience, this is for you also to participate. Anybody wishes to ask a question in between, just raise your hands. We will come across to you and take the question as well. It's going to be interactive, so please warm up. So the first question, hit the target on time. Sandeep Vaidya, I want you to make a quick rapid fire comment on each of these x-rays which will follow about the quality of reduction and the quality of the fixation. Ready?
Yeah.
Go. What's wrong here?
Yeah, so the wire configuration, it is, first of all, a medial wire was not needed for this type of fracture, and the medial wire is almost not holding the distal fragment.
Anything else? Anyone? What has he missed? Anyone from the faculty?
Crossing at the fracture site.
Yeah.
Bingo. Next, what's wrong here?
Yeah, so the anterior humeral line seems to be completely missing the capitulum. So I don't think the sagittal plane angulation has been corrected over here.
What else?
Wire configuration going from posterior to anterior. It should be from anterior to posterior.
All three wires are intramedullary. Anyone else? Next, what is wrong here?
Huge number of wires. I don't know whether they were needed. I need to see the initial X-ray, but the medial wire was probably not needed. It seems to be in varus. I am not sure, but the Bauman's angle seems more than 75.
No, you're quite good with that one. Too many wires don't guarantee a successful outcome. The reduction is more important. Just because you put in more wires, that does not mean more stability.
Also, all wires are short. None of them are bicortical.
Yes, perfect. Taral will be help actually if you come this side, but never mind. You can continue from there. And
Almost
this
all
one?
convergent wires. I don't know whether there is any hold in the distal fragment. There is rotation at the fracture site, so many things wrong with this X-ray.
Okay, thank you. And this one?
Again the same, there is no hold in the distal fragment. And, 3 wires, but I don't think anyone is giving stability. The fracture has already collapsed into varus.
And what is glaring at you in the face? Do you think this was reduced at all?
Yeah.
So the bottom line here is never pin without adequate stable reduction. If unstable, use additional maneuvers, but make sure your reduction is absolutely 100% stable on table. And when you realize that your reduction is not really coming, go ahead and use the maneuvers which Sandeep Patwardhan has shown us, but you have to get a good reduction before you proceed for fixation. Okay, we move over to Sandeep Patwardhan. Sandeep Vaidya has done extremely well. Mahaguru is judging you.
Quick comment on the last X-ray. There is a medial comminution that necessitates a medial wire.
Medial wire, yeah. It's a high fracture also, so I don't think, you can get a quadricortical wire there.
So,
So remember, the Mahaguru is judging you. He's going to decide who's done the best out of all the faculty. Sandeep, what were any limits to accepting different deformities in different planes? If you can comment on this slide.
sorry?
What deformities will you accept in what planes?
Okay, so coronal plane malalignment is totally not acceptable. Rotational malalignment is important because if they are not on pillar to pillar, it will collapse into varus, though it may compensate at shoulder. And translation is acceptable,
How much?
about 30%.
Is there anything that you know, any formula, anything that you can quote for the audience? What is the Gordon's index and how much should it be?
Gordon's index actually on a lateral film, if you see the proximal fragment like an AP, that tells you that there is a mismatch in the width and there is malrotation. So that tells you it's type 2B. The type 2 fracture is unstable. That is what its role is.
So this is the Gordon's index for the benefit of the audience. Prize question, when was it described, which year?
Gordon ko puchna padega.
That's the answer for you there. And this is Tristan in 2011 who said that at least 20% should be the acceptability limit of the Gordon's index. Over to Binoti.
So you can carry on.
You can ask. I'll click for you.
No, you can ask. It's okay.
All right. So this is for Manoj. I think Binoti likes me to grill the boys. This is a 9-year-old who came with a road traffic accident. What will you expect, Manoj, and what will be the primary management?
It's obviously buttonholed and come out through the skin. So all principles of open fracture management come into the picture. The way it's come, the hand looks white. So there is definite vascular injury. So you will need vascular backup. There is no need to do any preliminary investigation to confirm vascular. Extend the wound, inspect, reduce the fracture first, and then look at the vascular structures.
All right. Anything else you think you would expect there? Look at
Concurrent nerve deficit. I don't see any extension happening there.
one.
Yeah, probably a median nerve as well. Radial is definitely not working.
Bingo. So now, can you classify this fracture pattern? And what wire construct will you use? What will be the quality of reduction that you'll expect? And what is the prognosis for this nerve?
So reduction, standard reduction, the classification, this is, it looks unstable in both planes, so that would be an intra-op assessment, but Gartland 3 or a Gartland 4. wire construct, big fragments. So because you're opening it, you don't need to actually visualize the pinning. The reduction is achieved and the pinning is actually done under fluoroscopy. So you can use cross configurations. If the radial nerve is in continuity, prognosis should be good.
Okay, so this is what was done. Would you accept this?
In the context of the injury, the coronal plane alignment is pretty good. Some amount of sagittal translation extension, I would accept it.
And Premal, do you want to tell the audience what was done, because we want to move to the other cases?
I think that radial nerve palsy was there, and the radial nerve was between two fragments. So the first what we did was we extended the incision, first look for the radial nerve, separated it between two fragments, and then close reduce. I think it should not be close reduced when you have a radial nerve palsy and a wound like this. It may be a good idea to explore separate your nerve properly and then reduce.
And that's the result.
Right, so now Premal, continuing again with you. So this is a little unusual variety of a supracondylar fracture. So can you enumerate the displacements and how do you classify such type and what would you want to do? Anything
You
more?
cannot classify this with Gartland, but you can classify it with Legrand classification, which is a classification for distal humerus and gives you beautiful classification even for type 2, which is divided into two different parts. So this is a type 5 Legrand classification, which is, as Sandeep Vaidya showed, that this requires different, this is a comminuted diaphyseal-metaphyseal junction fracture, and this will not be amenable to your conventional K-wiring. It will require intramedullary fixation, either going from top to below as shown by Sandeep Patwardhan, as well as you can come from top to below as shown in your manual and shown by Sandeep as well.
So do you require any further investigation, because
yes,
it is not looking like a typical supracondylar with a lot of
There is
complications?
something happening in medial epicondylar area, but I think I would get a traction view rather than sending this child for CT scan, because that will waste a lot of time.
But this is what was done, so just for the benefit of audience, to show them how comminuted this was.
Yeah, so just as you rightly said, these were the child was taken up under anesthesia for close reduction, and these were the traction views. So are you happy with that?
I think this is fairly aligned, and I would accept that and proceed with the fixation.
Great. So as you rightly said, in these particular varieties, we would require little longer and intramedullary wires, and that was what was done. And 2 wires may not be sufficient to hold such a big diaphyseal-metaphyseal fracture. So 2 wires, cross wires, 2 from each side were done, and that is what is the reduction. Are you happy with it?
See, I think it's a fairly well reduced, but one of the wires does not seem to be going in the proximal fragment. So I just want to share a tip here that sometimes what happens is you want to put a wire and it's not going bicortically. In that, because it deflects from the opposite cortex. So in that circumstances, you can use a thicker wire, which is more likely to go bicortical than go in the intramedullary. But here, one of the wires is not in the proximal fragment.
So if I were to show you, this is what was the problem.
Yes.
The whole anterior chip didn't allow us to do that. Sandeep wants to...
It's a bad one.
Just an additional comment, when there is medial comminution and it's going to collapse into varus, an external jest to hold it in valgus is a very good idea.
So because the reduction was good, the fixation was fairly good enough. In child, the union potential and healing potential is pretty good. So we got a very good result at the end of 6 months. So coming to next question now for Taral. So we learnt about, Sandeep did mention about associated injuries. So this was a 9.5-year-old child who had fall from height. He had suspected head injury, which was cleared. He also had some abrasions, but these were his x-rays. He had fractures at the elbow and in distal forearm. So what would be your...
So this is, go back to the x-ray. This is importance of knowing the Bach's classification. And if everyone sees this x-ray carefully, you'll understand that there is a medial oblique supracondylar fracture. In this patient, if you try all lateral pinning, it's not going to be very stable. So this is a definite indication for doing a cross pinning, where one pin would go through the lateral condyle as a forecortex pin, but the other pin has to be a very carefully done medial pin, which I would do in little extension, saving the ulna now. So this is the comminution, and you should put a medial pin very careful in this patient.
Would you ask for any CT scan or anything for this?
Not really, not really.
So in this case, it was done because the child went for a CT for the ruling out head injury, but not required routinely.
Okay.
So now what will be your management plan for this child? What will you reduce first, elbow or distal radius? What will be the method of fixation? You've already told, but what will be your plan? First you reduce the elbow or you reduce the distal forearm?
No, my plan in this case would be to give a traction through proximal forearm, reduce the supracondylar fracture, which should not be too difficult. I'll pass the lateral pin first to secure the fragment, then extend the elbow and then pass the medial pin. And the distal forearm, I think I'm just going to treat it in a plaster. So I would give this patient a slab post-op, a double slab for the forearm and just a posterior slab for the supracondylar area.
So just as Taral said, everything was done. There was some difficulty, so some additional maneuvers were used and medial wire was used. But because the distal forearm was little higher up, a plate was used and a wire. But we are now actually focusing on the supracondylar. So just Taral mentioned as we have done the treatment and this was the good result.
So Binoti, can I ask all the panelists who would get a CT scan in this case before treating?
This was already done from before and we...
Just to get a message that it is not...
Yeah, it is not required. I said it was done when the patient went for CT of the head because patient had come with that. Nobody is going to ask for a CT scan for this.
Okay, we have just time enough for 2 quick questions from the audience. Anyone? You'll have to address to the specific faculty. Yes, gentlemen first, and then Dr. Mukhi.
Yeah, my question to Dr. Patwardhan. Sir, for supracondylar without any neurodeficit, either posteromedial or posterolateral, what approach do you take? And do you really need to isolate the nerve, as you've shown in your pictures, like anterolateral and anteromedial approaches?
Sorry. So that was, see, in 15 years, I think any of us haven't open reduced a fracture. With the leverage techniques and arm board and the maneuvering that we do, 99 out of 100 times we are going to get a close reduction. I have given you the pointers where in case you are not able to have that level of skill which has a small learning curve and you do need to open, look at where the proximal spike is. Once you go to that spike with your finger, get out whatever is blocking reduction and do a close reduction.
Yes. Okay.
What people, at least when we were resident also, what we were taught is a midline posterior approach, split the triceps, see the fracture, reduce it, in it, all that is not needed. What we know is that when you have a posterolateral displacement, spike is anteromedial. Put your incision on that, you are likely to get these 2 structures. Remove them, do a close reduction. If it is posterolateral, the radial nerve is going to be there. So that's just to tell you where to take the incision. That's all.
So we have the privilege of having our Mahamantra, Guru to give us Mahamantra, but before that we will summarize
Just wind up
learning
session.
objectives.
Because this session is Superhit Supracondylar fracture, let's see what is the super formula to hit the goal. So it's simple, remember super, study the fracture, understand the fracture personality, plan the reduction and fixation, execute the plan well and review the outcome. So you must know, like Sandeep Vaidya says, what is this fracture type, whether it is extension, flexion, what is the modified Gartland, remember Bach classification, understand the personality, not just the X-ray, but look at the neurovascular bundle because we know that is very commonly associated in supracondylar fracture and address them accordingly. Plan your method of reduction and fixation. Know the classic maneuvers, but also know the specialized methods like joystick, intrafocal. Be prepared for open reduction. Always an anterior incision is preferred. Execute as per your plan. Know what is the acceptable reduction, acceptable fixation, when you should put a medial pin, and then finally review whether you have executed your plan as per your study and understanding. If it is like this as seen on left, always revise. If it's like that, what is seen on the right, are you going to be happy and rejoice? Yes, for the time being, but don't forget to follow them up till you hit the goal of getting a good clinico-radiological outcome. And now I ask Dr. A.N. Johari to just sum up on the whole thing and give his final words of wisdom on this very common supracondylar fracture. Over to you, sir.
Well, first of all, thank you to Rujuta and Binoti for inviting me here. I would like to thank all the panelists. They have done an excellent job. Within the time allocation they had, they have done a beautiful coverage of the subject. Some areas which have been left out, of course, complications. The biggest bugbear of supracondylar fracture is complications, and what happens to the supracondylar fracture when not treated effectively? What are the complications like joint stiffness or cubitus varus or other problems, associated with supracondylar fracture? There was no time to tackle that, but that's also an important thing because the outcome is important when we talk of management. So a wonderful job was done. We started with the typical supracondylar fracture and its management. Well, epidemiology is important. Most fractures are extension types. The age group affected between 5 and 8 years. This is important because this has implications for the residual growth of the extremity. About 2 centimeters of growth is predicated at the typical age when supracondylar fractures happen. So if you have any problems, you may have a growth disturbance, and that will give rise to deformities, cubitus varus, for example. Now, most of these deformities occurs because we have not recognized two things, a medial comminution which is present. So the classification is important. The medial comminution is important. The Gartland 2A and 2B classification, which was modified by Wilkins, is important, but there are a lot of problems with this because of problems of inter-observer and intra-observer agreement. 2A, well, 2B is more easy to recognize. 2A may have issues of medial comminution and they may require fixation, though largely 2As are managed by conservative management. The periosteal hinge is important. Where does the periosteal hinge lie, And we have to take advantage of the periosteal hinge to reduce these supracondylar fractures. A good reduction has to be evaluated by radiological parameters which were not much stressed, the Bowman angle and the anterior humeral line. I think these are the two parameters which are very, very important in ensuring that you have a correct reduction, your reduction is good, And then the principles of fixation, Lateral pins are as good as cross fixation for most of the fractures. The rules of fixation, bicortical purchase, fixing both the proximal and the distal fragment, no intramedullary placement, and divergence at the fracture site. I think these are very, very important. These rules have been given by Sankar, and they are important to follow because very often you lose fixation if you do not have correct K-wiring of this fracture. Other areas, of course, the neural injuries, expectant treatment. Most papers, of course, go for expectant treatment in nerve injuries. It has been shown that whether you do an opening on the medial side and then pass your K-wire, or whether you do it closed, it makes no difference to the incidence of nerve injuries. We have papers on both sides. Vascular injuries, I think, was outlined very, very well. Vascular injuries, the way we treat them, of course, a white hand is an emergency. Pink perfuse, good perfusion, with stable symptoms, no increase of pain, pinkness remaining, movements are good, well, that's another kettle of fish, and that can be treated expectantly. Complications like compartment syndrome, I think, are important to pick up. Compartment syndrome can happen, especially if you have a vascular problem. And vascular problems, neural problems, there can be interposition which can prevent a good reduction. So if you have a problem with reduction, one may need to explore that particular fracture and do an open reduction. So these are some of the pointers I would like to give, And lastly, I think the fracture personality was mentioned by Sandeep. Fracture personality is important because there can be a lot of atypical variants of supracondylar fracture. And a classification, a new classification coming up is the isthmus of the fracture, that is through the coronal olecranon fossa, low fractures and high fractures. Well, different implications for all these particular types of fractures and their management. So I would feel that in passing, I would just have a comment that these fractures are getting more and more specialized, and in the future, I'll see that most of these cases would be referred, especially the complex supracondylar fractures would be referred to pediatric orthopedic surgeons and traumatologists. That's my feeling. Thank you.
Thank you, sir. Thank you, faculty. And I would request everybody to step down for a picture because we have the plenary Keti Dolakya oration to follow.